Okay, why don't we go ahead and get started. I want to welcome everyone to our Department of Psychiatry Grand Rounds and to everyone online. Our guest speaker today is a very special member of our department, and to say that he's homegrown, I discovered, is an absolute understatement. In reviewing his CV, I discovered that the further back I looked, the more connected he was, and I thought it was really interesting, and I think you might find it as well. So Dr. Morano began his journey in high school here at McDonough School, where he was awarded the medical school scholarship given to a McDonough graduate. He attended the University of Virginia, his only departure from the state, I think, where he earned his BS in engineering, and he did this with distinction. And then after a post-bac pre-medical program, graduated from the University of Maryland School of Medicine, followed by his residency in our program and a Department of Psychiatry and his geriatric and research fellowship at the medical center. A closer look revealed that Dr. Morano has been awarded many of our honors during his training, including the Fine Singer Award in medical school for excellence in psychiatry, the George Belize Award for excellence in medical student education as a resident, and the John Talbot Award for clinical excellence during residency. All of this was followed by a 4-year NIH extramural program for clinical research. So quite a preparation. Board certified in geriatric psychiatry, Dr. Morano is an associate professor and the division director of geriatric and acute adult psychiatry, with a well-established expertise in the treatment of neuropsychiatric symptoms of dementia and psychiatric disorders in medically complex older adults. His research interests include neuropsychiatric symptoms of dementia, the neurobiology of late-life depression, and the relationship between late-life depression and dementia. He completed a career development award evaluating the role of insulin resistance in the cognitive impairment of late-life depression and participated in clinical trials of pharmacologic treatments for the behavioral disturbances of dementia, as well as a multimodal imaging study of late-life depression and mild cognitive impairment. Most recently, he assumed the leadership role of the Advanced Depression Treatment Center, where we have, as many of you already know, TMS, esketamine, advanced psychopharmacology, and also extended ECT. He makes this available to those in need. So please join me in welcoming Dr. Morano as he delivers today's lecture, Schizophrenia, Aging, Cognitive Impairment, and Dementia.
So can everyone hear me okay? Oh, so thank you very much, Jill, for that introduction. I always hope to lower expectations before something like this. So I hope half of you stay awake, and I hope that 10% of you maybe learn something, but we'll see how it goes. So again, I'm Chris Morano, for those of you who don't know me. I have nothing to disclose financially. And talk a little bit, what are the objectives for today? Well, first, I want to review the relationship between schizophrenia and dementia, talk a little bit about some potential mechanisms for cognitive impairment in schizophrenia, review the evidence-based strategies for prevention of cognitive impairment in aging, and briefly discuss the relationship between brain biogenic alterations and cognitive symptoms in schizophrenia. And my preface is, I'm a geriatric psychiatrist, so I'm a little bit, much of the stuff I'm going to talk about here was actually done at the Maryland Psychiatric Research Center. So apologies in advance if I really screw anything up, and just give me a holler if I'm off base. So why do you think of this topic? Well, this topic comes really, kind of came to me clinically. And this is something we get constantly on our geriatric psychiatry inpatient unit. 72-year-old, doesn't matter, man, woman, with schizophrenia and dementia presents to UMMC with, you name it. So this is a really common introduction to the history of present illness in the physical exam history and physicals that we do when patients are admitted to our service. But really, what does it mean? I mean, and that's what I want to talk a little bit about today. I kind of first got interested in this when maybe I first finished training, and I talked to some people about it. And I was kind of advised, well, stay away. This is very murky. And indeed, it is very murky. So schizophrenia and dementia. So looking at this sort of as a clinician, what are the possibilities when we see someone present, schizophrenia and dementia? First, we could have delirium that wasn't picked up, right? The other thing we see not too infrequently is an acute exacerbation of psychosis mimics the symptoms of dementia. You're so disorganized, you look like you have dementia, and people say, oh, well, they must have schizophrenia and dementia. Could it be a neurodegenerative disorder initially misdiagnosed as a primary psychiatric illness like schizophrenia? We'll talk a little bit more about that one, and probably spend most of our time, is it something or many things about schizophrenia and its treatment that results in a progressive cognitive impairment or increases the risk of Alzheimer's or some other neurodegenerative disorder? So, talk a little bit about the misdiagnosis of a neurodegenerative disorder. In dementia, neuropsychiatric symptoms are nearly universal, and they can often occur before the cognitive symptoms. And if you look at the neuropsychiatric symptoms, I mean, everything here, I mean, it's widely varied, and anything here could potentially look like symptoms you see in schizophrenia, in major depression, in bipolar disorder, in an anxiety disorder. So there's really, the symptoms may be the same. There's even this concept of mild behavioral impairment kind of in the dementia world, which is sort of this idea that there's going to be sometimes the first symptoms of a dementing illness might come in changes in behavior and personality really before you see any cognitive, overt cognitive symptoms. So people decrease motivation, affective symptoms, impulse control, inappropriate social behavior, sort of lacking social cognition, and really psychosis. So this is something, always to keep in mind. So I was surprised when I was kind of doing this. I knew this happened, but when I saw this study, it maybe happens more than I realized. I think this is two large databases from the United Kingdom, and these are electronic health records. So remember, when you look at diagnosis in these, it's very rough. And what they wanted to do was they wanted to look at the association between 4 psychiatric disorders with dementia. And what they're looking at in these slides is, oh, my pointer's not, well, there it is. I was pointing the wrong thing. So what you'll see here is, this doesn't work so good, does it? So the important take home here is, if you look, this is showing you basically the time lag between first psychiatric diagnosis and diagnosis of dementia. So if you have a peak at 0, means they're happening at about the same time, which you see pretty much for all of these, regardless of the data set, except for maybe anxiety and depression, which is pretty well accepted as a prodrome of dementia. Diagnosing them at the same time is pretty much consistent with misdiagnosis, because you're not going to develop schizophrenia at, well, you could, but you're not going to develop schizophrenia at 65 and then dementia in the same year. So really, so this definitely does happen. There's one illness, though, I wanted to just touch a little bit more on, because I think it's one where actually you can really see how it happens. And that is frontotemporal dementia, or frontotemporal lobar degeneration. So this is a neurocognitive disorder, and really which the kind of hallmark is behavioral or language impairment before you see the onset of the cognitive symptoms. So these are kind of folks who might present with like profound apathy, loss of empathy, antisocial behaviors, stereotype behaviors. They can, at times, though it's not considered a core feature, they can appear psychotic. And when you look at it, really, when we're talking about the pathology here, we're looking at the you'd see the frontal and temporal atrophy on an MRI. Well, here's the thing. The one thing about frontotemporal dementia is it tends to present younger than, say, Alzheimer's dementia. It's actually in people less than 65, it's equally as prevalent as Alzheimer's disease as an early onset dementia. And people with frontotemporal dementia very often will present to a psychiatrist for their first treatment. And very often we'll get a primary psychiatric diagnosis. So interestingly enough, there's a case series actually looking at this. And it's not a large case series, but basically there were 17 patients who had frontotemporal dementia. And 5 of them were actually diagnosed with schizophrenia within the 5 years before the development of frontotemporal dementia. So it's really something, I mean, and there are some sort of potentially shared genetic vulnerabilities between the two, but this is one to pay particularly close attention to. How do we diminish this chance for this error? Well, this is what I say all the time to the residents when they come on the unit, so I'll say it again. Comprehensive evaluation is really so important when we're working with these older people. When we get a history, really need to get it from patient, family, and caregivers, and that very often includes obtaining collateral without the patient present. So people feel free to kind of talk about what's going on. And do not limit, when working with do not limit your history taking to the psychiatric symptoms. You always want to ask about cognitive symptoms, their presence, what's their course. Ask about functional symptoms like the basic and instrumental activities of daily living. And really a detailed family history. And the big things you want to make sure you ask about, and I always say is, dementia, is there any dementia, Alzheimer's, Parkinson's, or other diseases that seem to run in your family? Thorough physical examination, including your neurological exam. And this is very important because you might pick up some, particularly gait type abnormalities or abnormalities in motor function that could give you a hint that something else is going on. We do bedside cognitive assessments. On our unit, sometimes if we're not sure, and particularly if you think your bedside cognitive assessment may not be so accurate, whether it be based on sort of level of education confounds it or the current, psychiatric symptoms that someone's having, we do some formal functional assessment by occupational therapy. And then, diagnostic tests as indicated, blood, brain imaging, certainly MRI being preferred, and a lumbar puncture or EEG as indicated. Now, it's not to say that this is, you shouldn't make this mistake, shouldn't happen. I mean, there's certainly reasons where we see that it could. I mean, the dilemma of the DSM is that we're dealing with phenomenological diagnoses, really syndromes which may or may not have a common, etiology or pathology, but may look the same clinically. And, we all know about the overlapping symptoms and risk factors for schizophrenia, schizoaffective disorder, bipolar disorder, where you may have patient over a course of time that might look like they have any one of those, could meet criteria for any one of those. So, time is often our best diagnostic aid. And this will happen a lot, particularly if we do think this is an incipient, dementing disorder, it'll declare itself. So kind of shifting gears a little bit, I want to talk about sort of the epidemiology of this relationship. Is there an increased risk of dementia and schizophrenia? Well, yes, there is. So this was, a lot of this comes from Europe. We have, large health registries, but this was an interesting study. Nationwide register in Denmark, and 2.8 million people aged 50 and over, 20,000 of them with schizophrenia, followed over 18 years. So by age 65, the cumulative incidence of dementia was 1.8 in the folks with schizophrenia and 0.6% in the people without schizophrenia. So it's like a 3 times increased risk. Now, by age 80, this, everyone else catches up a little bit. So 7.4% in the people with schizophrenia and 5.8% in people without schizophrenia. And these risks really didn't change when adjusting for medical comorbidities like cardiovascular disease or diabetes, which we'll talk a bit about later. So this is just from that study. So I think the take home here is you see the blue line is the people with schizophrenia. And you'll see that they the dementia occurs at a higher rate, right, versus those without, and at a younger age. Because look, where right here we see this is starting much younger than it would be in people without schizophrenia. Now, the good news is the majority of people with schizophrenia and do not develop dementia, and this is kind of suggestive of the heterogeneity. Maybe this is a neurodevelopmental and neurodegenerative disorder. How about just looking at longitudinal cognitive course? So this is another big study in Suffolk County, New York. And basically, they have a first admission longitudinal cohort of patients with psychotic disorders. And they're actually able to go back and trace cognition from elementary school to old age based, you know, to sort of test, is this neurodevelopmental, this is neurodegenerative. And you can get the pre-admission cognition they kind of would extract from medical records and school records. So you got 428 people, 212 with schizophrenia and 216 with some other psychotic disorder, bipolar, major depression, substance-induced, not specified. And really, people could have some post-onset cognitive test ranging from 6 months to 25 years of follow-up. So really a long time. So what do we see? Well, two things here. I think on the left, this is really looking at its general cognitive ability as measured by IQ, okay? And what you have in the three groups is you have the gray line, I'm pushing the wrong thing. The gray line, right, at the top, this is people who are never psychotic. So this is sort of a comparison group. Then you have people with other psychotic disorders. So let's think about that like mood disorders, essentially, or substance-induced. And then finally, you have the folks who have schizophrenia. And what you see is you're starting out lower and you appear to be declining at a greater rate. The interesting thing, they actually kind of took it a step farther and looked at cognition and relative to timing of psychosis onset. And there you can even see, again, schizophrenia, folks with schizophrenia in the orange on the bottom, other psychotic disorders on the top, again, looking at IQ. And you see that the authors kind of proves like, really, people with schizophrenia lost about 16 IQ points during the observation period. And this even seemed to happen 14 years before the onset of psychosis. And it's more rapid in schizophrenia. And again, they say, again, that this looks, you know, kind of consistent with a neurodevelopmental and a neurodegenerative disorder. So what about untreated psychosis? Because, you know, we often hear that untreated psychosis is really, you know, a poor prognostic factor. So this is a study actually done in China, because we wouldn't really have probably large cohorts of untreated folks here. It's in rural China. Mean age, they looked at folks with chronic untreated schizophrenia and control participants, about 200 of each with a mean age of 51. And the median duration of untreated psychosis in these people is about 23 years. And they really compared the cognitive test scores between the two groups to see if there was some association of cognitive function with the duration of untreated psychosis. And essentially what they found was the untreated patient group performed significantly worse on all cognitive measures compared to controls. Not surprising. And also not surprising is that the longer duration of untreated psychosis seemed to track with significantly lower performance on several tests of executive function. Sorry, I didn't mean to put that, should say executive function, not cognitive function. So we do see there's something going on here in schizophrenia. Just a little, a note of caution here. So when I'm saying dementia, I'm just saying the dementia syndrome. We're not talking about etiologies. We're just talking about the dementia syndrome, which you see in the, kind of in our DSM-5 criteria, which we also interchangeably call major neurocognitive disorder. And we really don't need to go through the criteria. I think that the take-home point here is this is not etiologically based. And that's always a challenge in dementia research, because you're not going to be, autopsy used to be the way we would diagnose most dementia. Now we have imaging techniques to see, brain vascular disease, amyloid, Parkinson's pathology, sort of in living in patients who are living, but that's not easy to do on a large scale. So oftentimes these populations are looking at a clinical diagnosis of dementia. But that being said, what's important to remember, there's really a lot, there are many, many etiologies of dementia. And kind of the big ones I highlighted here, and we'll talk some more about: Alzheimer's, vascular, and sort of multiple etiologies, which is generally the combination of Alzheimer's and brain vascular disease. So real quickly, Alzheimer's, about 60 to 70% of dementias. Vascular, maybe about 10 to 15% have a pure vascular etiology without evidence of co-pathologies. But really mixed dementia with components of Alzheimer's pathology and vascular pathology is very common. And we also recognize that sort of the major Alzheimer's risk factors are vascular risk factors. And we'll talk some more about that in a bit. So really quickly, on the left, we have Alois Alzheimer, a psychiatrist, not a neurologist, and his first patient, August D. And interestingly enough, so he wrote in 1906, A Peculiar Disease of the Cerebral Cortex. So August D was 51 years old, and she had progressive cognitive impairment and psychosis. When she died, they looked at her brain, and they found these plaques and neurofibrillary tangles. And Kreplin kind of used Alzheimer's name to coin this in 1910 as a syndrome of rapidly progressive young onset dementia, which was different from senile dementia. Now, we kind of realize that's not the case now. But interestingly, remember, Kreplin also called schizophrenia, the initial name was dementia praecox. So, that kind of gives us an idea that there is some cognitive issues going on. So just real quickly as a refresher, Alzheimer's disease pathology. And really the big ones are, we have beta amyloid plaques, intracellular tangles of hyperphosphorylated tau, which sort of through a long cascade results in neuronal death. So what about that? Is some of this, this cognitive deterioration we see in folks with schizophrenia due to Alzheimer's disease neuropathology, these plaques and tangles? Well, kind of the short answer of it is that no, it does not appear that pretty much every study, whether looking at autopsy or even some that have looked at CSF biomarkers that are more recent, you do not see increased rates of plaques and neurofibrillary tangles in people with schizophrenia. Let's just to kind of go a little farther with that, we think about the kind of the Alzheimer's as an amyloid cascade. So if you start with a production of amyloid beta 1 to 42, the abnormal one, there's other processes. There's then the neurofibrillary tangles form. Then there's some other processes. You ultimately get neuronal loss, circuit loss, and then symptoms. Well, these intermediate steps, this is very important because there's a lot of other things that are contributing to this. And these are things that I think could also very well be contributing to some of the cognitive impairment that we see in schizophrenia: and inflammation, insulin resistance, which we'll talk some more about, lipid peroxidation, vascular insufficiency. And again, it's arguing to the heterogeneity of much of our diagnoses. And I bring this up to talk about this, when we look at pathologies, especially as people get older, it gets harder to tell. So this is a study of sort of Japanese American men between 1991 and 2003, 443 autopsies. And really, it was the combination of neuropathological lesions that kind of best predicted cognitive impairment later in life. Of course, there's Alzheimer's pathology, microvascular infarcts, so brain vascular disease, and atrophy. And both the vascular disease and the atrophy may be relevant when we talk a little bit more about schizophrenia. So let's move into that. What are some of the potential mechanisms of this cognitive decline in schizophrenia? Now, I will preface, this is a broad brush I'm going to be giving, and much of the work here was actually done by people at the MPRC, so I hope to do it justice. So really, you can think about four kind of potential mechanisms, or one way to think about it. And this is actually some other work done by one of our former residents, Ellen Lee, who now at UC San Diego, who kind of put this together and I thought a nice review. So you can think about low cognitive reserve, right? We really don't have that, don't have a kind of a cushion when insults develop later in life. Is it accelerated brain aging? Could be brain vascular disease, if we talked about. And then what about the medications that we use to treat schizophrenia? And I'm speaking specifically about antipsychotics and anticholinergics. So first, let's talk about low cognitive reserve. And I thought kind of the longitudinal cohort was kind of demonstrates this very well. You're starting out with a lower IQ, right? So you have less to kind of give, and you're deteriorating faster. So that sort of argues in line with that. How about accelerated brain aging? This is interesting. You can kind of see it in, again, this is oversimplification, but you can kind of, we think about atrophy, you think about gray matter deterioration and white matter deterioration. And really both of these you can see in patients with schizophrenia. So decreased brain volumes are kind of well-known feature of schizophrenia. Cortical thinning is actually seen pre and post development of the psychosis. White matter deterioration. So we know that white matter deterioration, think about the white matter tracks made of myelin, they break down, they don't transmit information as well. And you can see that with aging, age-related cognitive decline, and potentially accelerated aging in schizophrenia. We see that this is related. This degree of white matter disease is related to cognitive deficits in schizophrenia. And again, we see this in neurodegenerative disorders, including Alzheimer's, and very much of this work was done by folks at the MPRC. So how about brain vascular disease? Well, we know that the potentially modifiable dementia risk factors are vascular risk factors. And it's pretty consistent. It's smoking, midlife hypertension, midlife obesity, high cholesterol in midlife, and diabetes. Well, we know, that individuals with schizophrenia have about a twofold increased risk of having cerebrovascular disease. And the question is, there's maybe part of the pathophysiology, part of the lifestyle, and really we've all seen that the second generation antipsychotics can exacerbate these risks. How about the medicine? So, and this I've always found interesting. We know that untreated psychosis is not good for your cognition, but antipsychotic exposure is also not good for your cognition. And sort of it's associated with worse cognition in cross-sectional and longitudinal studies. Dose reduction, there's been some studies that show that dose reduction can improve cognitive function in a stable patient with schizophrenia. And there's one particular study that was actually looking in psychotic depression that found like treating someone with an antipsychotic can actually decrease cortical thickness. So maybe the medications aren't, or at least antipsychotic medications are not as helpful as we think. And this is sort of a kind of a potential, like, how could this potentially be happening? You think about your vascular risk factors sort of in this pathway 1 to the left. And then the authors posit, well, maybe there's this pathway 2 where antipsychotic exposure is kind of exacerbating the metabolic syndrome, and you kind of are starting out with prefrontal cortex is not working as well. The antipsychotics may deplete dopamine. You get further cortical thinning, and kind of this whole this whole combination ultimately results in dementia. So how about another class of medications that we really use a lot? The anticholinergics. So, anticholinergics used for sort of the Parkinsonian symptoms that we can see with antipsychotics. And we know that kind of, in addition to many other medicines that are anticholinergic, we know that cumulative anticholinergic exposure is really, in older people, is associated with an increased risk of dementia. We also know that, there's a sort of a dose-dependent relationship in schizophrenia between anticholinergic burden and cognition. But interestingly, unless I missed it, I could find very, very limited data on if docs have actually tried to get people off of anticholinergics and see if it helps their cognition, particularly now where we have second generation antipsychotic medications, which may not, have as much propensity for extrapyramidal symptoms. So really, I could only find one 12-week study in 20 patients, which isn't much, which did show, yes, it seemed to help some cognitive domains. Didn't really seem to hurt the EPS, but again, this is really doesn't seem like it's been replicated on any sort of large scale. Even beyond that, does anticholinergic deprescribing reduce the risk of cognitive decline in general? And again, we don't know either way. This is from a Cochrane review in 2023. There's really insufficient evidence to say, some studies show something, some studies don't. But the data is really limited here. If you look at randomized control trials, it's only 3 of them with a total of 300 participants. So really, I think the jury is out on anticholinergic deprescribing, if it's beneficial. Probably can't hurt, but yeah. So sort of switching that. So we've talked about some of the things that might be the mechanisms of, the cognitive impairments and dementia that we see in schizophrenia. Well, is there anything we can do to prevent this? The Lancet Commission in 2020 did a very nice kind of overview of what can we do to prevent dementia. And really, if you look at this, it's treat vascular risk factors, exercise, don't get depressed, have frequent social contact and maintain a high level of education, which again, that can be a challenge, in folks with schizophrenia, and avoid excess alcohol and treat hearing impairment. And this is actually, I think that's one where might be somewhat of an easy win. So let's talk about the vascular risk factors. I've mentioned before, you really need to treat these before symptoms develop, controlling hypertension, cholesterol, smoking cessation, again, another huge issue in schizophrenia, weight loss, exercise, elements of a Mediterranean diet. These all seem to be helpful. Remembering that Mediterranean diet is lots of fruits and vegetables, healthy fats like olive oil, little bits of nuts, red wine in moderation, though I think the data on alcohol is not looking good anymore. They used to say, oh, a little wine's good, but no, not anymore. Very little red meat, but regular fish, your omega fatty acids. And then is there anything we can do to enhance these cognitive protective factors, things like education, or you could think that's almost like using trying to learn, using exercise and social contact. Well, we know on a population level, we think that we actually have all, the way in which we manage vascular risk factors now compared to maybe 20 years ago is helping. So this is a population study, but basically what they found was that if you looked in 2000, about 11.6% of people over age 65 would have the dementia incidence was 11.6%. But in 2012, it's 8.8%. So it's gone down. It's significantly gone down. But during that time, we know that also people have more hypertension and obesity, and that these things get worse. So the idea is, well, maybe better treatment for cardiovascular risk factors, and that people may be obtaining more education to increase cognitive reserve could be helping with that decrease. But what we're really interested in is can we do this with our patients, right? The individual that's sitting in the room with us. And there's really three things I wanted to highlight here. There's diet, and really we call it, everything's got a fancy, acronym, the MIND diet. Mediterranean DASH, which is basically a Mediterranean diet, and the DASH diet, intervention for neurodegenerative delay. So you got the MIND diet. You have some sort of multi-domain lifestyle interventions. We have finger and then pointer. So finger came first. That was in Europe. Now pointer, we call it a pointer here. And we actually had a grand rounds on pointer last year from the Alzheimer's Association. And then take a little bit of look at hearing aids for hearing loss. So the MIND diet, you can think of it as a Mediterranean and DASH hybrid, really the emphasis is on dark colored fruits and vegetables. Like half of that should be on your plate. A little bit of, a quarter whole grains and a quarter of healthy proteins. So what are the things we want to encourage people to eat? Green leafy vegetables, nuts, in moderation, berries, whole grains and beans, fish, lesser extent poultry, and olive oil. Olive oil, I think olive oil is good for all. What don't we want? All those things that really taste good. So, that's the things. I'm being facetious, but all those things that are easy to get and usually taste very good. But good foods, the best foods can also taste good. So, does this help? Well, I put this up. This is just a recent meta-analysis, systematic kind of looking at the effect of the MIND diet on cognitive function in older adults. And basically, the take home here is it's been done, there's been 11 different studies, like 17,000 participants. For the most part, it seems to help. Yes, not every study shows that. I think the question is that always comes to test is how feasible is to implement? And number two, are we seeing clinically relevant differences? And this is really a challenge sort of in dementia research, because we can do something that may help a biomarker or maybe help a cognitive test, but how does that really turn into, improved clinical function? And oftentimes the timelines you need to figure out that information is more than you can do in a study. But MIND diet, I think, has some potential. What about these multi-domain lifestyle interventions? So this is the US Pointer study, and the results actually came out very recently. They didn't even have them when they were here last year. They just talked about sort of the study design. But let's take a look at this. So what they basically look at, you had one group that had a self-guided lifestyle intervention. So you have like these facilitated peer team meetings, 6 of them over 2 years. And they do education, some tools to facilitate self-guided plans, support encouraging physical activity, healthy diet, cognitive and social simulation. Well, what did the structured group do over these 2 years? Well, really at a community facility, they had a physical exercise program, aerobic, resistance, stretching, balance. They would support them with that through peer meetings, encouraged to follow the MIND diet, support with a peer group and telephone contacts, cognitive and social challenge. So you do some computer cognitive training at home. The peer support group, sort of an intellectual and socially engaging activity. And then guideline-based health coaching. So really you had a medical advisor and they'd see you every 6 months, review your blood pressure, your labs, kind of go over your goals. So did it help? Well, yes, it did help. Both groups actually showed some improvement, in cognition, both the unstructured and the structured one, but significantly more in the structured one. But again, the question becomes, well, we don't know if this is clinically, we don't have enough data to know if this is clinically meaningful. But certainly there's some encouraging signs. Same thing, this is the finger, which was the European study. This was 10 years earlier, but it basically showed the same thing. It was a very, very similar study. It's been replicated a number of times. And again, helps, maybe hard to do. Do we know how clinically meaningful it is? one thing that, and this just came out and caught my eye, there's been sort of this building literature about hearing loss and the risk for dementia. And they sort of, it's kind of it's a complicated study design, but basically the take home here is that hearing aid use really, if you found people who use hearing aids, they really following them up, 18 months later, they had a less chance of having dementia or not. So this is something that really, we know that hearing aids are associated with kind of paranoia, hearing loss associated with paranoia, associated with cognitive symptoms. So it's really something where we can, again, potentially an easy win. So I want to wrap up real quickly to talk about one other kind of mechanism, and this is brain bioenergetics. And this is kind of, I have to credit, this is, I had the really privilege and opportunity to work on a study that Laura Rowland had started, and I kind of saw it through the middle, and now Laura is back. And we sort of finished recruitment, and Laura's done some data analysis. So just a little bit we wanted to sort of talk about it. It's related. So what is bioenergetics? So it's really the capacity of cells to generate, transport, and utilize energy substrates, ATP, lactate, glucose. There's really a good bit of data on this in Alzheimer's disease, which I'll show in a second. And we're thinking, and again, this is a lot of the work that Laura and others have done at the MPRC, is that in schizophrenia, particularly seem to be some impairments in glycolysis and mitochondrial function, which may contribute to cognitive symptoms in schizophrenia. So what do we know about Alzheimer's? Well, cerebral glucose hypometabolism in the temporal and parietal lobes is really a consistent finding. And it's actually one of the ways that we sometimes will diagnose Alzheimer's disease if we're having trouble distinguishing it from frontotemporal dementia. And it's basically with an FDG PET looking at glucose metabolism. We also know that hypometabolism is associated with insulin resistance, and that insulin resistance in itself is associated with cognitive deficits. Now, turning to schizophrenia. So this is, again, some of the work at the MPRC, and basically using 7T magnetics. So magnetic resonance spectroscopy, you're basically using an MRI for spectroscopy, as a spectrophotometer, and you can really look at small levels of many brain chemicals. And in this one, really looked at lactate, and that folks with schizophrenia have increased lactate levels, which we think is like maybe due to increased anaerobic glycolysis. Okay, they're kind of using they're using more lactate than really you should, so you don't have it available for other things like long-term potentiation. So this could suggest kind of, maybe these bioenergetics are contributing to cognitive and functional impairments in schizophrenia. Again, also some other work from the MPRC is that insulin resistance, again, brain insulin resistance and altered brain glucose metabolism, you see some of these things similar to Alzheimer's in schizophrenia. So what about sort of the study? So just real briefly, and this is from Dr. Rowland actually presented this as a poster at the ACNP last month. And so this is sort of from that poster. So thanks to Laura for the use of the poster. So what was this study? So we had 60 healthy controls, 60 folks with schizophrenia, age 18 to 60, non-diabetic. Folks with schizophrenia were on a stable dose of antipsychotics, had limited use of anticholinergic and benzodiazepines, and no active substance use disorder. Comprehensive evaluation, medical, history, multiple psychiatric scales, and some blood work. So we used the BPRS for psychiatric symptoms, severity, and cognitive function was using the matrix consensus battery, which is commonly used in these kinds of studies. Fasting blood obtained, really to measure insulin and glucose, which allows you to calculate peripheral insulin resistance. It's something called the HOMA-IR. MR scanning done here at the University of Maryland, downtown at the Center for Advanced Imaging Research in neurology. It was a 3T Siemens Prisma. MR spectroscopy, which we did MR spectroscopy, structural MR, and used t-tester novas with repeated measures for our data. Okay, so real quick, I'm sorry, I'm running out of time, so I want to give it time. So real quickly, this is the where when you do MR spectroscopy, you have to look at a specific place in the brain. So the places that were selected were the anterior cingulate, the thalamus, and the occipital lobe to really look for differences between patients and controls. Here's the folks that we had. Things, yes, this male-female balance, we didn't do so great with that. You do see, looking at this, that there's significant differences in insulin resistance and cognitive scores between the two groups. And this is sort of some preliminary analysis on the data itself. So this is looking at, from the MR spectroscopy, the glucose and in the brain, right? And we see that in the folks with schizophrenia, in these three regions, there's higher brain glucose levels in the brain. We also see that, in these same three areas, in the folks with schizophrenia, that is correlated with increased insulin resistance. So we're seeing some of that relationship. Again, preliminarily, we didn't see differences in lactate with MR spectroscopy between the patients and the controls. However, we did see that lactate in the thalamus, lactate levels in the and glucose levels in the thalamus were associated with worsening cognitive scores in the schizophrenia group. So again, this is again pretty preliminary, but what we kind of saw was glucose levels are higher across these three brain regions in schizophrenia, likely reflecting impaired insulin, glucose utilization related to insulin resistance, higher thalamus glucose and lactate related to poor cognition, higher thalamus lactate levels, I didn't point out, are related to more positive symptoms. And sort of this is the big one. What do you do with all this? The idea is, well, could an alternative energy source to glucose be beneficial in schizophrenia? So I just want to say thank you very much. Like I said, I had the opportunity to really work on this grant, which was sort of started and obtained by Dr. Rowland, and then moved to me, and now Dr. Rowland's back. So the MPRC, just want to thank Laura, Frank Gaston, who does our image analysis, actually Dr. Kelly, Sharon August, who did a lot of our participant exams, Josh Chiapelli also did, and then Brian Brandler helped get us started. Also could not have done this actually without some great help from the Department of Psychiatric Services Research. Wendy Potts was our, our study coordinator, and just fantastic, and Melanie Bennett. So thank you so much for getting us started. And then we had folks in neurology that we worked with in the Center for Advanced Imaging Research. Now, I didn't get into a lot, but this is also a multi-site study, multiple PI study, different aims. But we also had collaborators at Emory and the University of Toledo. And just kind of last thing I wanted to say is I wanted to kind of give an acknowledgement to Rao Gulapalli. So Rao was the head of the Center for Advanced Imaging Research, and actually we started working with Rao on this study, and then he unfortunately passed away rather quickly after a battle with cancer. But just want to say thank you to Rao, and I know he's been was of great help to a lot of people in our department in imaging research. And thank you very much. So, all right, we have a let's see. Let me see if some questions.
Have some time for questions, Chris.
Okay.
Chris, I do have one question.
Yes, ma'am.
The conclusion that, increased exposure to antipsychotics can worsen cognitive.
Right.
Schizophrenia. And since the entering onto the scene, the atypical second generation, there's been really an uptick and a propensity to use those medications for non-psychotic disorders, mood stabilization, agitation. Is that same risk associated with non-psychotic?
That's a very good that's a very interesting question. And I will say the one study I'm aware of was one where they used for looking at it in psychotic depression in older folks, where they actually did serial MRIs. They said, yes, again, that's one study. I think they were using, I want to say they were using was it olanzapine? I can't remember off the top of my head. But so yeah, I don't know if there's more out there on that, but that's certainly, I think, something that is something to be looked at. And I didn't bring this up in the talk. If you do look at kind of most psychiatric illnesses do show some increased risk for dementia and cognitive impairment. Probably the most robust kind of study of that has really been in depression, but but you see it in bipolar. It seems to be more exacerbated, more in schizophrenia, but you kind of see it. So that's a very good question. I wish I could give you a better answer. Dr. Reeves, I also want to thank Dr. Reeves who helped me get this. I forgot to get everything started.
So first of all, thank you for mentioning Rao. He was a great friend to our department. So I have a two-parter question. One is about the science and the other is about the scientist. The science question is just so interesting about the association between hearing loss and early onset cognitive decline. And I'm wondering if that teaches us something more broadly about thinking about perceptual disturbances, particularly psychotic symptoms, as like maybe introducing new target mechanisms for dementia. And then the scientist question is, there's so few physician scientists in the field. Chris, we have a lot of young trainees, physician trainees in the audience. Could you just share anything about like why take this on as a physician scientist and how does that impact your career, your life?
So first off, I have to say I wouldn't if a physician scientist, I'm like this much of a physician scientist, maybe not this much of a physician scientist, but what I would say, I think it is really, really so important because we don't have enough people to really take these really, really exciting things that we can see in animal models or on the benchtop and take it into trying to help our patients. We've gotten so specialized and we're hyper specialized in everything, which makes it really hard, to do two things, right? To see patients and do things. I will say, and this is what I don't have, and it's probably why I'm this much of a physician scientist rather than this much, is stay focused if you want to be a scientist. Keep your eyes on the prize, stay and spend a lot of time on your research. So, yes. Dr. Ehrenreich.
I have a very concrete question.
Okay.
So cognitive decline is worse with untreated schizophrenia.
Right.
Cognitive declines associated with antipsychotics. Can I assume the first one is worse than the second one?
That's a good question. I would have to punt that to someone from the MPRC. Dr. Richardson, you're a schizophrenia expert. What do you think?
About which is worse? I don't know if you can say that. You have to take in all these other things into account, like the symptoms.
Yeah. I think what we can say is we need other treatments that use a different mechanism. That's probably the biggest thing. And maybe we've got that now, right? We got one other one. So, we'll see what happens. So that's probably the biggest point I could take from it.
The other thing, lowest effective dose. So often we get sick and we keep adding medicines or eat doses. But when they sort of get back to maintenance level, sometimes we forget to go back down slowly, back down to what is formerly a maintenance dose that they do fine.
And then before I get really two quick things from the chat. So I think this is from Cindy Schaefer. Cindy asked, what's the point of doing a comprehensive neurocognitive assessment once dementia symptoms are prominent? if differential diagnosis doesn't point to differential innervation, especially given the agitation and noncompliance of those affected. Well, that's absolutely, that's correct. I mean, when people with neurocognitive disorders, yeah, you do these kind of assessments early because late in the course, everything kind of converges into the same, set of symptoms. People can't do basic activities of daily living. Language has deteriorated, gait has deteriorated, urinary incontinence. So yes, absolutely right. And then Dr. Forrester had just sort of a note for everyone. She left a link, so please check it out. In honor of Black History Month and in line with the topic of today's talk, she has an article in the work of Dr. Solomon Carter Fuller. So, well, thank you all very, very much. I appreciate your time and attention, and hopefully 50% stayed up. That was the goal.